Hello everyone, this is Dr. Jimenez again. Let us now discuss what are the key differences between neuromyelitis optica and multiple sclerosis. As we all know, these two disorders belong to same spectrum of disease, that is autoimmune demyelinating syndrome, and they both present somewhat similarly, that is the symptoms of optic neuritis or involvement of spinal cord, like sensory deficits or autonomic dysfunction, right? We'll see what are the key differences and how we can differentiate these two disorders. So coming to the pathophysiology, NMO is because of autoantibodies against channels, that is we get anti-aquaporin IgG antibodies, right? They are specific for NMO. But in multiple sclerosis there is autoimmune attack on myelin sheath by mainly T cells and B cells, and we don't get any specific antibody in multiple sclerosis. And in CSF what we get is oligoclonal bands, which we don't get in NMO, right? And in the primary target in NMO is astrocytes, whereas in multiple sclerosis it's myelin and oligodendrocytes. Okay, now coming to the clinical features, age of onset, it's somewhat same, mid-aged female, right? 30 to 40 years in NMO, 20 to 40 years in multiple sclerosis, and predominantly females are affected in both the disorders, but the ratio is 9:1 in NMO and 3:1 in multiple sclerosis. Course, almost both the disorders will present with relapsing and remitting type most commonly, but in NMO rarely we get monophasic, but in multiple sclerosis we can get most commonly three types, that is relapsing, remitting, primary progressive and secondary progressive, right? But most commonly both will have course of relapsing and remitting type. Coming to the key symptoms, in NMO will be severe optic neuritis, and often they are bilateral. This is what you have to remember. But in multiple sclerosis, it will be unilateral, right? The symptoms will be painful loss of the vision or diplopia, right? And ophthalmoplegia. But in NMO, it will be bilateral, and multiple sclerosis, it will be unilateral, correct? And if you see the spinal cord involvement, in NMO, it will be longitudinal extensive transverse myelitis kind of picture. But in multiple sclerosis, short segment myelitis will be there. So there will be continuous vertebral segments, spinal segments will be affected in NMO, that is more than 3 segments are affected. But in multiple sclerosis, it is less than 2, right? So it will be short segments are affected. Next, in NMO, we'll get brainstem symptoms like intractable hiccups and nausea, etc. In MS, we'll get cerebellar symptoms also, ataxia, vertigo, and fatigue, which are common for both disorders. Vision loss, it's severe and bilateral in NMO. In multiple sclerosis, you'll get mild to moderate and often unilateral vision loss. Okay, recovery, if you see NMO, they'll have incomplete recovery typically, and in multiple sclerosis recovery is more common after initial episode. So that is what it's called as dissemination in time. That patient will be having suppose symptoms of optic neuritis now, but after some time he'll recover completely and he'll have second set of symptoms which may be because of spinal cord involvement, that is sensory deficits, or maybe autonomic dysfunction, that loss of bladder and bowel control, right? So there will be complete recovery in the cases of multiple sclerosis. Now coming to the MRI findings, as I said, in NMO the spinal cord, it has longitudinal extensive lesions, that is more than 3 vertebral segments are affected. But in multiple sclerosis they are short segment lesions, usually they are less than 2 vertebral segments. Coming to the brain lesions, often absent in the early stage but can present in the later stages, and they can involve if there is high aquaporin 4 expressions regions, that is hypothalamus has these channels, medulla and periaqueductal gray. But if you see the multiple sclerosis, common location in the brain is periventricular plaques, that you get Dawson's fingers in this MRI scan, juxtacortical and infratemporal lesions. So if you see the McDonald criteria for multiple sclerosis, in that the dissemination in the space in that 4 regions are given, that is periventricular area, juxtacortical, infratemporal and spinal cord, and more than 2 sites. These plaques should be present in the more than 2 sites, right? Next is in the enhancement, you see patchy and longitudinal enhancement, and in multiple sclerosis you will see ovoid, ring shape or incomplete ring enhancements because of the plaques. Okay, now coming to the lab findings, as I said, in CSF we will get oligoclonal bands in more than 90% cases in multiple sclerosis, that is specific, right? But in NMO you won't get oligoclonal bands. Mild pleositis, that is increased WC kind, can be there. You do a CSF, if you see oligoclonal bands, that favors more multiple sclerosis, right? And you'll get key antibodies, that is anti-aquaporin 4 immunoglobulins, right? And in some cases you'll get anti-MOG antibodies in some NMO spectrum disorder cases. Okay, and as I said, there are no identified specific autoantibodies in multiple sclerosis. Coming to the treatment, so in acute relapses, what you give is pulse therapy with methylprednisolone or Lex. This is same for both, right? You have to give, if the patient is present with acute relapses, you give the pulse therapy, patient will be all right. But in maintenance therapy, the difference is in NMO, what we give is immunosuppressants like azathioprine, MMF, and rituximab. But in multiple sclerosis, we have some special drugs, that is immunomodulators, that the examples are interferon beta, glatiramer acetate, and monoclonal antibodies like natalizumab, ocrelizumab, right? Other than that, fingolimod, one drug is there. Other than that, dimethyl fumarate, one drug is there, right? So what is in NMO, if you use these disease modifying agents, which we specifically use for multiple sclerosis, if you use in NMO, it can worsen the NMO, right? For example, interferons, if you use in neuromyelitis optica, it will worsen the disease, right? Coming to the prognosis, long-term disability, severe disability is more common in NMO due to incomplete recovery, right? Multiple sclerosis is progressive but slower disability accumulation will be there. Relapse risk, it's high in NMO without maintenance therapy. Okay, and multiple sclerosis, it depends on the which multiple sclerosis subtype is there. That is primary progressive, secondary progressive, relapse remitting. Okay. So now let's summarize the topic. So there is a battle of neurological titans, right? Neuromyelitis optica and multiple sclerosis. They may share similar symptoms, but the differences lies in the details, like what antibodies are present, imaging, and treatment, right? Spot the differences. Now NMO strikes with long spinal lesions and bilateral optic neuritis will be there, while multiple sclerosis plays its parts with periventricular plaques and remitting relapses, right? Antibody divide. Who's the villain in NMO? That is anti-aquaporin 4 antibodies. And in MS, there are no specific autoantibodies, but we'll get oligoclonal bands in CSF, right? MRI tells the tale, right? In NMO, we'll get long lesions that is more than or equal to 3 vertebral segments, and in multiple sclerosis, we'll get short segments that is less than 2 segments are affected. With that, we'll get Dawson's fingers in the brain, and MRI doesn't lie, right? In treatment, if you see, MS loves disease-modifying treatment like interferons, but NMO hates them. So we have to give immunosuppressants like azathioprine, rituximab instead of this. Eyes and spine in focus. NMO strikes the optic nerves and spinal cord with fury. That is, severe symptoms will get without complete recovery. Multiple sclerosis, it's more scattered game of the brain and cord attacks. Thank you.